Anybody travel to a place where they used antimalarials? Yes, yes, yes. Okay, so what they've told me in the past, in all my travels I've never had to do this. I've never been to the countries that are most at risk. Most of them tell me this is not the way people do it. So what I'm telling you is this is the way the CDC recommends it. And I left off some of the more unusual drugs. I've given you most of the very common ones. So those of you who've had to do it before, you're welcome to chime in. I'd love to hear what you said. But so I'm just going to go with the recommendations because that's all I know. I've not had any experience with it otherwise. Okay. So did you know that up until about the 1940s we had malaria here in the United States? So where do you think it most commonly was? South, swampy areas, Louisiana. So between like 1947 and the mid-1950s, there was a big push in this country to get rid of malaria. So they did lots of spraying, household spraying. It was amazing to read the history. And by about 1951, they declared it eradicated in this country. We have extremely rare to see malaria in the United States. So, if you look on page 2, there's some details about it. It's mostly caused by a parasite in the genus Plasmodium, and there's all different types of them. And it's carried by the female Anopheles mosquito. So, the parasite is carried by the mosquito, and the mosquito has to bite somebody. When you look at just the life cycle, you go, oh, did anything like this have evolved and exist? We'll go through it, but it's just incredible. So it is an international health concern. 214 malarial infections every year. Close to 500,000 people die every year of malaria. Main areas of concern, Africa's #1. Most of the cases come from Africa. Central and South America, parts of the Caribbean, the Middle East, Central Asia, and Southeast Asia. So it shows you there 79% of the cases were acquired in Africa. So the CDC has great, if you are dealing in that area, if you deal with a lot of international travelers, CDC is the best place for you to go and find out what the recommendations are because they'll tell you if they are chloroquine resistant or sensitive, because that's the primary drug that's used, and they'll give you the other agents that are options. So risk of contracting depends on where you're going, depends on the time of year you go. So the mosquitoes are in drier, colder times, they are not as active. Also depends on when you are active. So the mosquitoes are most active at night. So if you're out and about at night, you're more likely to get bit. Depends on where you stay. If you stay in a facility that doesn't have good windows or doesn't have adequate screens, then you're at higher risk. There's all kinds of things on the CDC website about mosquito control. So DEET is a very good mosquito repellent. They recommend you sleep under mosquito netting. That has been treated with pyrethrin. So Dim, you're shaking your head. Anything to add to that?
Just everything you said recalls from microbiome, but that's about it.
Oh, okay. Travel-wise, you guys that have traveled, what did you do, Sarah? Where'd you go that you were at?
I had to be on malaria calls both when I was in Haiti and Sierra Leone.
Okay, so what were your sleeping situation like?
In Haiti, we didn't have any sort of mosquito nets or anything, but yeah, we were there for like a week. In Sierra Leone, most of the places I stayed had like a treated net that was highly encouraged that we use.
Okay.
Yeah.
Michelle?
I would have Honduras. I think they just said take these if you would like. It's an
Really?
option.
Okay.
Yeah.
Did you take them?
I don't think I ended up taking them because I heard there were side effects.
Yeah.
I took them when I went to Haiti, and they made me super sick. So I was actually there, like, on a mission to like help out at a medical clinic, and I ended up being a patient instead of being able to help out. So yeah, the last like 3 days I was in their like hospital there because the malaria medicine was making me like super sick.
Yeah. Hannah, did you say you had?
I did the same thing. I went with a group, and they were a lot of them were like, yeah, we were told to take them, but we didn't take them.
Well, I know.
Both times I went to Haiti, first time I don't remember what antimalarial we were given. And they just told us to spray our beds with bug spray, basically. And then the second time I was actually on doxycycline when I was in Haiti in the middle of summer, which is kind of funny to me because of the photosensitivity.
Yeah.
Yeah.
So that's an effective. Fong, when you've traveled, do you ever had any experience in it?
In Vietnam, there's a lot of cases about the malaria, and the way we prevent it, we use the lemongrass.
Oh, yeah.
Press it and then put it on the body. So it
Really? Okay. Instead of any other type of bug spray.
No.
How about?
We don't have that luxury.
Okay. Jim, been back to Vietnam?
Never been.
Never been.
Never been.
Wow. Okay. So, do they any type of sleeping,
Yeah.
like netting? Do they use netting?
Yeah. So we recommend it to put up the net to prevent a mosquito bite. But in the middle of the night, you're gonna put your feet out of the net anyway.
Okay. All right. So realize that there's prevention and there's treatment. So the recommendation is that if you come back from an area, like if you guys had come back and you developed a fever, it's recommended you report it right away because it has serious neurologic. So some of the parasitic stages are in the red blood cell. And that's usually what gives people their symptoms, is when those red blood cells burst, then people get feverish, and that's the sickness, the malarial fever. But those parasitic stages causes the red blood cells to stick to vessel walls. And so what happens is they get down into the very small vessels in different organs. And eventually you get ischemia and you get damage to those organs because blood flow gets blocked. So that's how you get kind of total body, and it's considered a medical emergency. So we're going to talk about prevention. I'm not going to talk about treatment. It's not very common in this country. However, the CDC has a phone number you can call. And if you've got somebody who you suspect is having neurologic symptoms due to malaria, you can call them and they have specialists who will walk you through what to do. So I think I gave you one of the numbers somewhere. And just another. Okay. So on the bottom of page 2, most of the drugs we have, and you'll see on the next page, are going to treat that erythrocytic parasitic stage. There is also, though, well, let's just look at the next page. Look at page 3. So if you start up there on the left at 1, so a mosquito bites you that's infected. So that form, and those are called the sporozoites. This is like a Star Trek story. So the sporozoites, they go into the bloodstream and they head to the liver. And they can set up residence in the liver and stay there for months to years. So this is how people have relapsing malarial episodes, is because what's in the liver can then migrate out of the liver at various times. You'll see that there are drugs that that are effective with the parasitic stages that are in the liver. You'll see the aminoquinolones, and then if you look in the liver itself, you see the atovaquinone, proguanil, and primaquine can act on those forms there. So they have a different form when they get into the liver. They're called schizons. I don't even know if I'm saying it right. Once they rupture and they spread into the bloodstream again, and they enter red blood cells. And they multiply there and they take a different form in the red blood cell, and they burst, and that's what gives people their fever and chills and most of the symptoms we associate with malaria. If you look there in the very center of that blood stage, you'll see the quinolones, which are usually the most, we have a lot of drugs in that category that will help with the blood stage, the antifolates and the antimicrobials, which would be like the doxycycline that Haley talked about. That last group is a group of drugs that come out of China. that some people use to treat. I'm not going to talk about those per se today. Then some of those different, let's see, it's the trophozoites can then become gametes and produce those parasites again, that which if you're bit by a mosquito again, then they'll pick it up and take it to somebody else. Now, is that not unreal? Can you believe that an organism has developed that weird kind of life cycle and still persists? If you read back through the history of malaria, it was mentioned back in China 5,000 years ago, so they've been around forever, and we still keep fighting them. So you can read through, the liver does not produce any symptoms, but becomes kind of a reservoir of parasites that can then continue to keep that cycle going. You do not have to know the names of those different cycles, but or different parasitic forms, but you should know which drugs affect what part of the cycle, like are we affecting liver or blood or gamete production. Okay, top of page 4. So fever and influenza-like symptoms, chills, headaches, muscle aches, malaise. And there's that medical emergency, and there's the malarial hotline, just so that you know one exists. They've got people on call during the day, and they have, I didn't give you the other number, but they've got people that are there on nights, on weekends as well. So very few mosquito-borne diseases can be prevented with medication, but malaria can. It's one of the odd ducks. So the classes that we're going to look at are the quinolones. The most of them are there. Some of you've heard of before. We've talked about chloroquine and hydroxychloroquine. Where do we see those? Lupus, probably one of the big ones. Methylquine and Primaquine. So a lot of it in the quinolone derivatives. In fact, when you go on the CDC website, they will tell you in the area that you're going to if it's a chloroquine sensitive or a chloroquine resistant area. Then the antifolates, there's proguanil, and then the antimicrobial, mostly the tetracyclines, and I use doxycycline as a representative there. So chloroquine is good because it hits most of the different species, the variations, most of the Plasmodium. But it does have resistance with some of the different groups, but still is effective for the Plasmodium ovale and malarial and vivax. Those are the most common. So that's good. So that's why chloroquine is still good. It gets into the tissues and it stays there. It takes about 2 months to get rid of it. So that's good because you're going to see as we go through, one of the difference in drugs is how far in advance do you have to start it. They all recommend that you take it while you're in the area, and then how long do you have to take it after you leave? Sometimes you have to take it for a week. Sometimes you have to take some of the drugs for 4 weeks. Some drugs you have to start several weeks before you go, and some you can start a day or two. So those are the ones to keep in mind. So if you're planning a trip, you can start well ahead of time. If you're a business traveler and you're having to go with on a few days' notice, then there are other drugs that are effective in very short periods of time. The other thing I want you to note is which ones are weekly and which ones are daily. So the quinolones are mostly once a week. So that's good. You only have to take a drug once a week, but if you miss it, you have missed a whole week. So if adherence is a problem in terms of remembering, then that might not be the drug for that person. So side effects. Most of them are all in this same category: headaches, dizziness, abdominal discomfort, vomiting, diarrhea, blurred vision, insomnia. Which ones did you have, Sarah? Do you remember which drug you took?
I don't remember, to be perfectly honest. It was something they gave everyone that was in our group. But I was super nauseous. I was very lightheaded. I felt weak. I felt fatigued. And at first I thought I just hadn't drank enough water because obviously we're out in the hot sun.
Yeah.
But I got really well hydrated, and so it was just
So
I felt like I
they have
almost
to
had the flu in a sense.
Okay, so she's giving you a great description of it. So they hook you up to an IV?
I was like, I'm supposed to be helping other people, not getting
Okay, so severe adverse reactions are rare. The one I want you to keep in mind is that retinopathy. If you remember back to lupus, one of the things with hydroxychloroquine is that it's the total dose. So most of the time, people are going to hit that dose with this, but if they're multiple travelers, if they're already on a hydroxychloroquine for something else, they may not need the drug added on. They'll probably have adequate coverage. Okay. Drug interaction. So the one thing I do want you to remember is a QT prolongation. So I've given you a little chart, reasons to use, once a week. Good for long trips because it's only once a week. If they're taking hydroxychloroquine or chloroquine for some other reason, they probably won't need anything in addition. And you can use it in pregnancy. So some drugs you can't. Reasons not to use. Resistance exists. It can exacerbate psoriasis. If you don't want to take a drug weekly because you don't think you can remember it, it's not a good choice for last minute. And you have to take it for 4 weeks after you get back. Hydroxychloroquine, it's almost identical. It is touted to be a little bit better tolerated. Still once a week, start it 2 weeks before he travels, take it 4 weeks after you get back. Mefloquine is a really good one in this group, but it has lots of side effects. So that's what you need to star at the side, is it has unusual side effects for this group. So it can be used where malaria is chloroquine sensitive or chloroquine resistant. So here's its contraindications. Lots of neurologic complications. People who have major psychiatric history, family history of psychiatric illnesses should stay away from this drug. It also has cardiac conduction abnormalities. So think brain and heart when you think this drug. If they have had allergies to quinine or quinidine. So quinine, an old drug for malaria. Quinidine, an old 1A antiarrhythmic that some people may still be on. And it prolongs QT interval. Always note that. This one is start once a week or 2 weeks before travel. It's another one where you have to take it for 4 weeks after. So note those. Note the differences. Splitting the dose is thought to decrease some of the side effect potential in some folks. Next page, top of page 6. So it has a black box warning for dizziness. And the reason it's there is because it can persist. After they get home and they quit taking the drug, it may not go away. So the conduction abnormalities, the sleep disturbance, the neuropathies, it also has a rare pneumonitis. So you can see why it's not first line in this group. You have to be, I think, fairly young and healthy to be considered. So it's a 3A, it gets messed up by 3A4. It is a substrate for it, so things that inhibit it or induce it is going to be a problem. It also affects drugs that are metabolized through that P-glycoprotein pathway. So reasons to use: adherence, can be used for pregnancy. Reasons not to use: psychiatric, seizure, conduction. Can't use it the last minute, and once a week may be hard to remember. So that one stands out. The other two you can lump together. Okay. The 8 aminoquinolones, so back at that page, where are those effective? Well, it's effective in the liver area, so you can see where it would be good for, and why you take it long term is because the ones that hit the liver are usually the ones you see that you take for at least 4 weeks after returning. So this is Primaquine. So it is used when you're going to an area that has malaria that's most likely due to Plasmodium vivax. The problem with it is it's a G6PD deficiency. It causes a hemolytic anemia. We've talked about this drug a long time ago. when we were in, I think, pulmonary. So people who are going to use it have to be tested. So they recommend not using it until people are tested. The others, they recommend not using it in pregnant women because even if the mom is not G6PD deficient, the baby could be. EKGs, long QT intervals. So this class of drug, all of it prolongs QT interval. So you don't want to use it with other drugs that cause QT prolongation, which are what? Say it again. Citalopram? Yes, citalopram. What else? I just couldn't. Zofran. Macrolides. Anything else? Say what? The azels don't come to mind. You thinking of one in particular? I have to look back. I don't remember, is honestly. It could be. So we talked about that. This is daily. And this one, you start 1 to 2 days before, and you take it for 7 days after.
Special testing.
Yeah.
Going back to mefloquine,
Uh-huh.
on the second bullet point under indications, it says it can be used where it's chloroquine resistant, but in the table on page 6, it says can't be used where resistance exists.
Well, I think that's where there is resistance to that drug.
Oh, okay. The specific
I'll go back
drug?
and I'll verify it.
Okay.
Okay, so on top of page 7. So again, this is for Primaquine, so it's got that specific Plasmodium vivax. Good for short trips because you can start it quickly and you don't have to take it as long. So G6PD, keep that in mind. Don't use it in pregnancy. Prolongs QT interval. Antifolate. So proguanil is a folate blocker, and so that makes it hard for an organism to produce DNA. The atovaquone, do you remember where we've seen it before? Well, we talked about it a long time ago. It's not a very common drug. It's an antiprotozoal. We talked about it with pneumocystis pneumonia back in Poland. So it's only recommended in mild. It has very few indications. But this one, it's always used in combination with proguanil. So you get 2 mechanisms of action for that. If you look back to the picture, look at where it exerts its effect. So it's very useful in people that have liver involvement. It also can be used in that blood stage. Okay, so it can be used in where resistance is for chloroquine or the other quinolones is present. Don't use it in kids, little kids, pregnant women, or renal impairment. So that's the first time you've seen that pop up. It's taken once a day, 1 to 2 days before travel, and then 7 days after. So there's 2 camps. Those you start 2 or 3 weeks ahead of time and you continue 4 weeks after, or those you start 1 to 2 days in advance and take 7 days after. Has lots of drug interactions. That's what I would keep in mind. Warfarin, but also look down there, rifampin, rifabutin, so think TB. So for people who are immigrants from areas where malaria or TB is more prevalent and they're coming back and forth, those are the folks that tend to get in trouble. Okay? And those would be the ones that would likely be on TB drugs. Okay? A lot of people that travel back and forth tend to think they're immune or resistant, so they may not seek out pre-travel help or care. They may consider that, you know, I go back and forth all the time, I'm resistant. They are the ones who are probably at most risk because they lose any immunity they have is shortly lost if they're in this country for any length of time. So remember that with that drug. Well tolerated, more expensive. Okay, last one, and then we're done. So the antimicrobial. So several antibiotics can be used. Clindamycin falls into this group, the tetracyclines, doxycycline. But I'm going to just stick with doxycycline for this one. It's a relatively slow drug, so it's always paired with something else. But if you're traveling to areas where you may be at risk for other type of infections, let's say you're going to hike, ticks, you're going to be in water, bugs there that, and you've got water that's not clean. So for people who are going to travel in those areas, this might be a good add-on. And they would get effects as well. So you know all the people to stay away, pregnancy, young kids, because of the tetracycline effect on bone and cartilage. Again, it's a 1 to 2 days before travel, take it while you're there, and 4 weeks after. It's a little bit different from the others. Remember, with tetracyclines, it's usually GI upset, the photosensitivity. You heard Bailey talk about you taking it while she was in Haiti. Think that. You'll remember the phototoxicity. Vaginal candidiasis. Anytime you give women an antibiotic, you put them at risk for yeast infections. It's also one of those that complexes easily, so staying away from iron or calcium, or they say bismuth. So bismuth would be part of like a traveler's diarrhea treatment, is where that probably comes in. And then oral typhoid vaccine is just one of those odd ones that stands out. International travelers would probably be the only time you're going to come across that. That is all I know about antimalarials.